was we were talking about differential diagnosis versus a field impression. What's the difference? Differential diagnosis, field impression.
Differential diagnosis would be a very specific list of things that you think are going on versus the field impression is more of a broad, I guess, broad impression.
Okay, I like it. So as an EMT, which one have you been doing? Field impression, okay? So the idea one more change in your life is this. The idea that from here on out, you need to be thinking of at least 3 different possibilities, and preferably more than that, preferably 5 possibilities in terms of what do you think is going on, okay? Why? Look, that's true. I'm guilty as charged of that, but what else?
Danger care.
Yeah, so the idea in terms of a broader scope will not get you tunnel vision to thinking of chest pain is always a chest pain, right? Okay. What else about it?
Instead of ruling one or the other out as you continue interventions and treatment.
And that's exactly right. The idea in terms of how you take it from here down to here is what we're talking about. So spot on, the idea that working through your movements. When you get into cardiology next month, we're going to be talking about H's and T's. H's and T's is nothing more than rule-outs. The idea of working through a system to find out what's going on and how we would go about treating. And that's what we're talking about here today. So what you know yesterday versus what you're going to know 4 months from now in terms of differential diagnosis is going to change. That is, all the stuff that we're cramming in your head, you're going to have that much more that you're being exposed to and coming up with a decent differential diagnosis along the way. So it's an ever-changing landscape for you. And oh, by the way, you somehow think that your learning will stop just because you happen to leave these hollow walls. Not true. The idea that it's ever focusing, ever changing along the way is part of your learning process. So in EMS, we tend to think about ducks. And if it looks like a duck, walks like a duck, acts like a duck, it's most likely a duck. So the idea in terms is not so much about differential diagnosis as it is, this is what we think is going on. So why should it matter? Just got to kind of finish talking about that. It's going to determine the probable cause of a patient's complaint can mean the difference between transporting to the right spot and the wrong spot. Now, if you happen to be over in Coogee County, the idea that you have a one-shot hospital is kind of an anomaly. If you get here, is it going to make a difference in terms of going to deep north versus taking you downtown somewhere in a huge way, right? And so it plays a part in terms of where you're going to for your transport decision. It equips you to make informed decisions. The idea of talking to your patient, the idea this is what I think is going on with you will help you out in terms of differential diagnosis. It fights against you becoming complacent along the way in tunnel vision. And so as an EMT, the idea that we train you, that we teach you, the idea that it's going to be this, or this, is not so much. It's going to typically be just one thing. So the idea in terms of this whole process starts at 30,000 view. So you're flying along and you're looking down at the possibility you're coming into a call, and so you're starting with a big old funnel to try to figure out as to what's going on. What are the possibilities? Is this a single gunshot wound? Is it a single patient? Is it multi-system trauma that we're going to talk about tomorrow? This then starts to drive your decision as to what you're going to do. Are you going left or are you going right in terms of your assessment, in terms of your treatment along the way? Steps in helping you with the differential diagnosis. Develop the possible causes of the patient's symptoms anatomically. What do you think we're talking about? Anatomically. Yeah, so the idea we're talking about a COPD patient, the idea that it's going to involve the lungs, it's going to involve the heart, perhaps it's going to involve something in terms of neurological side. So those are the 3 systems I'm going to be thinking about as far as my assessment goes. Those are the 3 systems I'm going to be talking about and answering to and everything else like that. An organ system framework, good for vague symptoms. The idea that if you don't know anything else that's going on, you can start with this process right here. So second phase is about possibility, probability, prognostic, and pragmatic. What's the difference? Take a look at those 4. What's the difference? Sure. What's the difference between those four things? One, two, three, four, those four things.
You're getting an idea of what's going on by possibilities. You're narrowing it down to a likelihood of what you're getting based off your general impression. And then you obviously jump to the worst possible case scenario just to make sure you cover what your worst case scenario.
So which one do we typically go to the first in our world?
Serious.
Yeah. So the idea in terms of this right here, if they've got if you walk in and you hear stridor along the way, are you going to pay most attention in terms of airway? I sure hope so. I hope that though you're not going to forget about everything else that's going on with them along the way. But the idea in terms of prognostic, we're going to treat the most serious first. And sometimes, in all honesty, you may not get past anything with prognostic. And so to that, you take care of the most serious based on what's going on. Okay. The next thing is pragmatic, most responsive treatment first. So the most critical thing, take care of, and then most responsive treatment first. The idea of coming up with a mental list of possibilities. The idea of starting broad and narrowing it down is what we're talking about here with differential diagnosis. The list of the R's. I'm not going to ask you to recite the R's to me, but let me just talk to you about it. So sit back and chill for a second. We're going to react to life threats. That is, going back to this right here, we're going to think about the most serious causes along the way. Okay, so we're going to react to that. We're going to read the scene and your general impression. What's a general impression again? What's it all about? Sick or not sick, right? It's going to guide you as to which way you want to go, what your treatments are going to be, where you want to go in terms of transport, how you're going to get there. Your general impression will help guide you towards that, okay? Respond to your finding. The idea that your patient has a raging 9 out of 10 chest pain is you're going to start responding to trying to treat that chest pain along the way, right? And so that's what we're talking about as far as responding to what you're finding as you go. Reevaluating your treatment plan. What's the significance of this right here? Reevaluating your treatment plan. Trending, and is it working? Do you need to go to plan B? Do you need to go in a different direction as far as treating your patient along the way is what we're talking about. And then to that, revising as you go. And then finally, reviewing your performance. And so part of QA/QI is this, but it's also about you in terms of what are your next steps. You still have 10 to 15 minutes left on your transport. What do you need to do in terms of what's going on with your patient? Make sense? Nothing earth-shattering there, folks. So then we start the narrowing process and using all the information that you've gathered to this point, the vital signs, the history, the medication, the what's presenting for you, the general impression. All that is part of the narrowing process to get down to the possibilities. And so while you walk in with this big old funnel up here, you walk in not knowing exactly what's going on, the idea that you start narrowing it down to work down towards the top 3, top 4, possibly top 5 along the way. To this point, because chest pain is a very common type of thing. When you walk in, somebody's got chest pain, everybody's a cardiac patient, right? When in reality, not really. Did you know there's 400 and some odd reasons for chest pain out there? Did you know only about 75 of them are related back to the cardiac side? That means there's a whole host of folks out there with chest pain that are outside of the cardiac side. And so to that is all about this as far as narrowing it down based on their signs and symptoms and their history. What tools do you have? Assessment. I sure hope that you get great with assessment. It goes back to being a great EMT, but a better paramedic if you can do that. The idea of OPQRST every single time. What's ASPN stand for? So the idea of rule out, the idea in terms of patient admits to, patient denies, is part of your rule outs to help you narrow this down. Good listening skills on our part is something we've been talking about since day one in here. The idea in terms of thinking about outside the box as a possibility of what's going on with your patient. Your diagnostic toolbox will include cardiac monitor, pulse oximetry, perhaps a RAD-57 for carbon monoxide, capnography, stethoscope, glucometer, medications, and oh, by the way, your gut feeling. The bells and the whistles going off in your head should get you alerted to the possibilities. When you start denying that gut feeling, you're probably going to miss some things along the way. Field diagnosis is the most probable cause of the patient's complaint based on information gathered from your assessment. That's you, and that's what has been you. What's changing now is that you're going to start thinking broader for the other possibilities that exist along with it. In the end, can you stand before the doc? Can you stand before your medical professional that you're going to hand this patient off to and justify exactly what you did and how you did it and why you think what's going on? Does it mean you still can't be wrong? Again, I'm here to attest. I do it way too frequently as far as being wrong about something. But the idea that there is a good mental math or getting to what you're getting to is the bigger thing about it. Make sense? So part of the decision-making requirements is, we talked a little bit earlier about knowing anatomical as to what's going on there, the possibilities beneath all that. The pathophys side is what's going on as well. Congestive heart failure would be a good example of that. Knowing what's going on with congestive heart failure, how it works, and why they can show up with chest pain at 3 o'clock in the morning. Sifting through large amounts of data at once, you know how this goes. You walk into a scene and somebody's talking history, somebody's talking physical exam, somebody's talking about vital signs, and the idea of putting it all together is something that's not new to you. You've been doing that for a big deal. Fighting off ambiguities. What are we talking about? Fighting off ambiguities.
Finding details and things that don't seem that provide lack of.
That's part of it. What else?
Ask a question of ourselves.
Yeah, not so much. That's what we're talking about here.
Complacency?
Yeah, complacency is part of it, but the other thing about that is when we fight off ambiguities, that is that your patient has 9 out of 10 chest pain. How long has it been going on? It's been going on for 2 weeks. Oh, well, no big deal. It's been going on for 2 weeks. No big deal. It's probably nothing tonight. But the idea, that's a good example of ambiguity that just kind of blood in the water, but you don't know how much blood in the water. And so that you can become complacent along the way. Doing the right kind of assessment for what's going on with your patient. Organizing information and ideas. So the idea of you getting organized as to how you're going to ask your questions, the idea you get organized in terms of what are your next steps is kind of what we're talking about there. The idea in terms of this, and this goes right back to this right here, in that asking the right questions and getting rid of the rest of the information that doesn't apply to you. One of the things I purposely do to you on a written test is I give you a whole lot of information in a paragraph. And there's probably at least a third that doesn't apply in terms of the scene that you're on. But the reason I do that is why. So you're going to sift through all the minutiae to get exactly what you need to know. And that's exactly what we're talking about here. Analyzing, comparing similar situations. So the idea that you've been on a similar type patient with chest pain, with the same presentation that looked like so-and-so on a cardiac monitor, is comparing to past episodes. And hopefully you'll learn by past episodes too, right? And then again, standing for some sort of medical professional that you're going to explain whatever decisions you made along the way. And 9 out of 10 times, if your thinking is grounded in pathophys and good anatomy, then you're going to do just fine. We've talked about this for a long, long time now. The idea in terms of it's not working the first time around, being willing to shift to a backup plan or a plan B. All right, let's go to work. So let's see, Alex, this looks like yours. Read it out loud, please.
The dispatch to a 70-year-old male patient who will rotate around the patient's line on the bathroom floor. His collar is white. Wrapped by the patient line on the bathroom floor, he is pale, cool, and clammy. His pajamas pants are down around his ankles.
So what's obtunded?
Lessen the state of consciousness.
So obtunded is a decreased level of consciousness. Put that into your notes. You're going to need it again. Okay? Obtunded is a decreased level of consciousness. So when you're talking to that doc, when you're talking over radio, your patient is obtunded. Gives them a clear picture of what your patient looks like. All right. So in this case, he's obtunded, he's pale, he's cool, he's clammy. His pajama pants are down around his ankles. Okay? Why is he in the bathroom floor with his pajamas down around his ankles? So he's going to the bathroom. So why are you getting called to this? Say again?
They can get up.
Perhaps. That'd be one possibility, right? He's falling, he can't get up.
They go down.
They go down, right? So again, from a prognostic standpoint, what's my going in thing going to be? They go down. He break it down based on sitting on a toilet and the store, right? But if I leave it there without hooking up a monitor, if I leave it there without doing a great patient assessment, I'm probably going to miss a third-degree block that we happen to be in that we didn't catch because we believe that they go down. That's what we're talking about in terms of differential diagnosis. Does that make sense? So you're working through the process. So, Alex, where do you want to go with this? By the way, that's a kneecap. If you didn't figure that out. Where do you want to go?
Where do I want to go?
Yep.
Full assessment of that.
Okay. What else?
Vital signs.
Good.
Bit of history.
Good.
If there was witness, fell, or just kind of slumped to the ground.
Okay. So why would medications be a big deal to know in this scenario?
Blood thinners, beta blockers, anything like that.
Right. So the idea that medications can point to you in terms of the possibilities of this right here. What else could this be besides him begging down or him just falling? What else could it be? Yep. I want to know whether or not he's got an upper GI bleed, a lower GI bleed. I want to know whether or not he's got a history of alcoholism, that he's bleeding out through Behr disease. And so it goes on and on in terms of possibilities. Okay. So what do you think, Alex? Sick or not sick?
Based on initial assessment, I'd say not sick.
Okay. The only reason I would disagree with you is this right here. And he's got skin signs that would say probably something going on, right?
I'm not sick would be I'm not going to pick him up, rush to the hospital. Right?
Okay, based on what you're saying, okay?
Wouldn't you be offended just coming out of the?
And exactly. You may not know that, so you're spot on. The idea that you walk in, he's still coming back and being in the so-called bagel type thing, possible. But if you just assume that's what it is, then again you're going to get burned along the way. Okay. So Alex, give me 5 possibilities. I've already given it away to you, but 5 possibilities.
Simple, bagel, just fell, GI bleed, or some sort of
Cardiac issue, right? Okay. His wife tells you that he was using the bathroom and then heard him let out a yell as he collapsed to the ground. He has a history of a brain bleed. We didn't get there yet. 2 years ago. He has been ill for the last week, and especially the last couple of days. He is currently taking Plavix, which is what? It's a what? Blood thinner, right? What's lisinopril? Hypertension, right? And then vitamins, okay? So I think it's probably good that his blood pressure is well controlled. What did you say? What is that blood pressure telling you? He's hypertensive to begin with, right? And even if he's been taking his medications, is this significant in terms of blood pressure? Okay, is this significant? Okay, is this a bagel by itself? Why?
Vital signs don't match that.
Yeah, you're right, and so the idea in terms of the bagel will not hang here. It's just a simple bagel. It will take care of itself usually within just a couple of minutes, right? He's got respiratory at 16. He's static at 78%. His glucose is 130, so we can rule this out in terms of hypoglycemia. So, ching, one gone, hypoglycemia, it's not. Patient is somewhat responsive after you start high flow oxygen. Why is that a good thing? He's at least heading in the right direction as far as his response to you. Does that mean that life is all good, you can go home now, get a patient refusal? Probably not, right? Have you ruled anything in or anything out, Alex?
I ruled out diabetic issue.
Okay.
That's kind of as far as we got.
Is this a respiratory issue? Probably not. Based on what you know at this point, is this a GI bleed? We don't know in terms of the rest of the history, so maybe, maybe not. Okay. Is this a brain bleed?
Probably not.
Okay. Based on this right here, probably not. Okay. How do you want to go? Or what do you want to do?
Probably take 12 lead. See what we get from there.
Keep going.
12 lead.
His room air sat was 78%,
Sat.
or getting him on some high flow oxygen, right? And then reassessing that. What else?
Sit him up, Steve.
So I don't know that I'd be in a hurry to sit him up, and especially if he fell. Is this a cervical spine type thing? Maybe, maybe not, right? So you got to work through that process. What else? What else, folks? Say again? End-tidal CO2, if you had that right away. But again, the end-tidal CO2 in this presentation is probably, might tell you a little bit of a retained CO2, but end-tidal CO2 should not be a big deal in terms of this presentation right here. Is it nice to know? Oh yeah, without a doubt. Always is. But the idea that it may or may not help you a whole lot at the moment. Okay, what else you want to do? Without a doubt. It'd probably be my number one. The idea in terms of doing good head to toe trauma assessment along the way. The idea in terms of especially spending some time with that abdomen, big deal. Okay?
Should we be thinking about an overdose on his lisinopril?
Without a doubt. However, typically lisinopril will not give you this acute presentation right here.
Yeah.
If we're talking about some other cardiac abnormalities, then yes. But all by itself, lisinopril overdose would not present this way. He's got some difficulty breathing, and he has some chest pressure. The plot thickens, right? Physical exam reveals moving upper extremities and right leg without motor weakness, lungs that are decreased with absence heard over the right lower lobe of his lung. Now what are we thinking? Don't know. Don't know. What are you thinking? What do you think about this right here? Did this just zig left as far as putting cardiac into your differential? It should have anyways. It should have the idea of an old guy going down and not knowing exactly why he went down. You should be thinking about cardiac uno number. And so to that, you're starting to work down through this. Does that mean it's cardiac all by itself? Can it still be a GI problem? So in our differential diagnosis, we've got a cardiac of some kind. We've got the possibility of GI bleed or something along the lines of. Okay. What else might it be? Sepsis would be the other thing. Absolutely. So the idea that this guy has an unusual presentation for sepsis is 3, even before he gets started with this. So you see how the game is played.
If he had sepsis, he would be presenting as cool though.
Not always, but I got to tell you that when you think that the rule book is always going to be about somebody with a temperature of 101, and especially the elderly population to where they can generate that 101 temperature, that's why I always have respect for the possibilities of thinking outside of the box of what we're talking about. So you started an IV. How are you going to run fluids on this guy? So going from the 78 to this, you want to run some IV boluses carefully. Why? Sure, but why carefully? That might be one. What's another one? Yeah, not so much that, but the idea that he's been laying flat, the idea to get some respiratory distress going on, the idea you put a bunch of fluids onto his lungs to where there's already decreased breath sounds on that one side. You want to be real careful about that.
So, Jeff, if it's been developed for a while, can it decrease the lung sound?
Yep. Okay. Yep. So he now has blood pressure of 90/60. His pulse is up. Respiratory rate is still consistent. Pulse ox is 86%. So still not great in terms of this right here. We would pursue getting that up some more along the way. Do we want to back off the fluids here? Yeah. Do we want to do anything with this right here?
What's his normal?
There you go. There's the question. And if you're not asking that, you just assume that, well, you know what? I read in a book that a normal pulse is somewhere between 60 and 80, or excuse me, 60 and 100. Why is it now up at 130? Why is the body not compensating well with this?
Pretty good drugs.
Yeah, and so the pretty good drugs is probably a beta blocker. The idea that the body will not respond with a tachycardia along the way based on this right here might give you a clue as to what's going on. Oh, by the way, these are beta blockers. It's one more possibility into the cardiac side of life. Make sense? So what do you want to do with this guy? Rapid transport or not rapid transport? So definitely to the hospital. Are we running like in siren with this guy? Probably not. 12 lead would give you some information along the way. Well, now we're talking about a heart block. We're talking about some other abnormality. But putting the picture together, what three things would remain with you? Certainly a cardiac, its own kind, right? Sepsis, maybe, as a possibility. CHF is another possibility. So again, you're looking at 3 or 4 things even before you get started with this guy.
So
Okay?
where would you start on that? Number one,
Cardiac.
just rule out cardiac.
Yep.
Go to the next one.
Yep. Yep. And you were spot on in terms of getting a 12 lead. Why get a 12 lead as quickly as I can. All right, Christina, yours.
Hi, you're dispatched to a busy intersection for unconscious male. The updated route indication is laying face down to what's occurred and nobody wants to touch him.
You haven't read this one before, have you?
No, none of us. You're right to find a crowd gathered around the 45-year-old patient and law enforcement around. There's nobody around that knows your patient. Nobody witnessed anything.
This is your life on a daily basis. So what are you thinking?
Trauma, overdose. Did he have the big one?
Yep.
I mean,
Endless possibilities, right?
Yeah.
So are we talking trauma? We're talking about medical, right?
Yeah.
And so you're spot on. The idea there's probably 25 different things that it could be. What's your priority in terms of going from here to here as far as narrowing it down?
Well, I want to, if he's laying supine, great. I want to make sure he has an airway. If he's on his belly, I want to take C-spine, roll him over. Airway first, rapid trauma assessment, and then we'll start, vitals.
Check.
Does he have any holes in him? That's
Right. So from a prognostic standpoint, you're thinking about critical things that has to happen first, right?
Yeah.
And so that's spot on. That's exactly where you want to be.
Breathing, circulation.
Okay. He's breathing slowly as you approach him. There's a pool of blood on the ground around him.
Okay.
Little water here.
Yeah. So we want to find where that's bleeding from and stop it then. Sorry.
Check.
First. So cutoff is again. I mean, we're gonna do the trauma assessment.
Depending on the time of the year, yeah.
Yeah, we're gonna if he's on the ground, we're gonna take C-spine.
Yep.
And start cutting off his clothes, find out that major bleeding, and stop that major bleeding.
Yep. If that major bleeding happens to come from an airway, then it's going to direct you as to which way you're going, right? Okay. What are your priorities? Exactly what you talked about. C-spine, checking where that bleeding's coming from. What else would you want to know about him?
What else do I want to know? I want to know if he's allergic to anything,
Check.
if anybody knew him, and if he was on any meds.
Check.
I want to know a lot of stuff.
Check.
But, check pupils to see maybe it was our heroin overdose. Does he smell like he has ETOH on board?
Check.
Any head trauma?
Check.
Was he hit with a baseball bat?
Yeah, because I will tell you in all honesty, if I'm looking at this, and then I'm looking at this, I'm gonna be thinking about something with head trauma. Head trauma would be my number one thing that will come to mind.
What is
ETOH is alcohol. Another way of abbreviation for alcohol. What's your top 5 differentials, Christina?
Head trauma,
Yep.
you said, some kind of trauma is bleeding.
Okay.
So, overdose.
Yep.
Could have had the big one still.
Yep.
And, God, it could be something as simple as a sugar fix.
Yep.
I mean,
So hypoglycemia, we haven't ruled that in or ruled it out, right? So all possibilities, and we could easily come up with another.
I mean,
Yeah, we could easily come up with another dozen on top of that. Okay.
Oh. So he's got some ice. He's got some ice. So high pressure, high pulse. We need to. We're gonna put in OPA. If he has no facial trauma, obviously, drop the OPA, start bagging him. Unconscious. yeah, I'm gonna take that airway, and I'm gonna have my partner and my lovely partners in the fire department. We're gonna start ventilating him, and then we're gonna set up for our side.
Absolutely. And so the idea that you may not know, you may be stuck taking care of this guy's airway. You may never get to the point of anything past that to figure out what's going on, right? This certainly would give you a clue right here, right, for the possibility of some sort of a bleed. Okay. Why is it significant in terms of this right here? Yeah, poor perfusion. Absolutely. So it makes me go, I wonder how long he's been laying out here, right? A day such as today, not a big deal, but a day to where it's getting down to 10 degrees or something like that, it's a big deal in terms of him laying out. Has another part in terms of this.
So somehow low blood sugar cut his arm.
But does the blood sugar, that's this.
No, there's still a head injury. I mean, there's
Absolutely.
that's just extra fluff that's nice to know now.
Right. So the idea, this goes back to what I was talking about last week with D50, okay? The idea that are we going to want to dump a bunch of D50 onto this guy with a possibility of this right here. This is you as critical thinkers, folks. This is you in terms of managing your patient, much more so than what you've done to this point. Does that make sense? So we're kind of opening the door for where you're going, what you're doing.
It's gotta have some.
Yep, without a doubt. And so we carefully titrate to just trying to get some change in terms of this right here. That'd be my biggest concern. So before dropping an airway in this guy, we want to probably dump a little bit D50 on him and see what happens in terms of this right here. Okay? But it doesn't explain this. Right? So you still, in terms of your differential diagnosis, certainly hypoglycemia is one that's documented, right? But I would be still thinking about a head bleed. I'd be still be thinking about trauma as my third thing. And that's even before you get started with anything from a metabolic standpoint.
Now, is there something inherently wrong about pushing the full amp on that, expecting the brain bleed?
So yeah, there is, as a matter of fact, and let me. It's a good time to come out and do that. So the idea in terms of giving a bunch of D50 on somebody with a head injury is going to increase intracranial pressure. It's going to increase intracranial pressure. So the idea, like you said, the idea that they need to have glucose for energy to here is a true statement. The idea that it doesn't have to have a full amp just because that's what you're used to give it. Okay?
That's not because of volume.
No, nothing to do with volume. It's about the hyper side of that. That's all it is.
We'll go into that more detail later.
Yep. We'll talk about that as life goes on. So he's fairly well dressed. Does that account for anything? The fact that he can't be out swimming along just because he has to have a nice suit on? No, but the idea that you probably would not expect somebody in a certain neighborhood based on that.
Why is he still in his wallet then?
So this certainly helps you in terms of differential, but let me just caution you folks. The idea that when you get to this, based on this right here, the idea that when you lose track of this, because of something else going on, you're going to get burnt. That's why we're talking about differential diagnosis. All right, let's see, Michelle, this looks like yours.
You are dispatched to residential for general illness. Your med medication is moderate until symptoms there is a diagnosis. You are by a 63-year-old female laying on the kitchen floor. She seems a little confused about this person placed and can't say anything.
So how many times do you see this patient? Right? Another one of your bread and butter type things. Okay? So Michelle, what are you thinking about from the door?
What is order this?
Yep.
History has
Yep. Why would meds be a big deal here? You're right, but why would it be a big deal?
because they accept the meds.
Yep.
taken too much and stuff.
So you're thinking about the possibility of an overdose.
Yeah.
Okay. Is there any other reason that meds would be a big deal here?
Gotcha. Thanks.
Yep, true enough. He said may have forgotten to take some. What else though?
Probably about it.
Yeah, true enough. The idea that she happens to be on warfarin, the idea that she's been laying on the floor, the idea that she's bleeding somewhere into her brain, will tell me a whole lot from the door. So getting that as part of your differential diagnosis is going to help you along the way. And you already knew that as far as being medications. What's your general impression? Sick or not sick? Okay, so let's see, isn't acting right, would give me a clue. Daughter tells you, daughter should know history of mom, right? So isn't acting right would give me a clue. Because she happens to be an old lady, and I can speak from experience, old lady in terms of lying on the kitchen floor. Why is this significant right here? What do you want to know?
Why is she on the floor?
Yeah. There you go. The bigger deal in terms of how long she's been on the floor. She's been on the floor for 5 minutes, and she's been on the floor for the last 8 hours. It's going to have a huge, huge difference in terms of which way this is probably going to turn out. What do you want to do with her? What's your priorities? Good? Like that? What else? Yep. Until you figure out otherwise, right? What else? Okay. That. Good. Like that? What else? Good. 12 lead would be a good thing. Even without any history, any other history, 12 lead would be a helpful thing. What else? There's something else that I'm fishing for. Why is her laying on the kitchen floor significant to you? Yeah. So hypothermia and trauma do not play well in the same sandbox together, right? So a secondary injury would be considered hypothermia that she's been laying on that kitchen floor. And oh, by the way, you studied this last week. You may not know it in this presentation, but you studied this last week. This is possibility, yeah. But this is a hyper K waiting for you to diagnose it. The idea is she's been laying there for hours and hours and hours and hours, and it's hypothermic along the way. It's going to kick potassium. And so the idea in terms of you recognizing that, the fact that she's been laying on the kitchen floor. Now, I'm guarantee you as an EMT in the past, you never ever thought about the possibility of hyper K, right? But to that, this is what we're talking about from a differential diagnosis. Daughter tells you that mom lives by herself. What does that tell you right there?
Generally okay.
Generally, she takes care of life pretty well, or at least we think. I mean, there can be some circumstances, right? But for the most part, it looks like she's independent, okay? Found her on the floor today, unknown on how long she's been there. So again, she's got, we don't know if she's got pajamas on or anything else like that. So we don't know literally how long she's been there for. She tells you that she became weak and decided to sit down. She denies loss of consciousness. Doesn't admit to epigastric pain. How's that a big deal? Yeah, I would be considering both sides, both the GI bleed and still the possibility of a cardiac type thing. Does have a history of TIA. Is that significant to you? Oh yeah, right. Does have a history of hypertension. Stents placed in her heart 6 months ago. She's a train wreck for a lot of different possibilities. And so check this out, folks. You may never ever, and I may never ever get to the bottom line of what's going on here, but the idea, that's why we come up with our top 3 or 4 hit lists, and that's the direction that we're going to take her. Does that make sense? And she might still be something else. Once you get to the hospital, she might be something else along the way that we go, didn't see that one coming.
With the history of stroke or TIA, the stents, she's probably on things, right?
Not probably. Yeah. So again, she's hypotensive. However, in this case, she's got a pulse that's responded pretty well in terms of tachycardia. Respiratory rate is 36. She's setting at 88. Glucose is 126. So can we rule this out right here? So at least there's one thing we can rule out along the way, right? The idea in terms of what do you want to do with this? Please don't tell me you want to slow her down, okay? Right. So the idea. This is the one game in town that she's got going on to try to compensate for what's going on. What kind of acid base do you suppose this is? Depending on what you want to know about this, it's what kind of tire line, but I definitely would be thinking about a metabolic type thing. So the idea of slowing this respiratory rate down for that, if it's shallow and she's not moving a whole lot of air, that's one thing. But assuming that she's moving a fair amount of tidal volume, slowing this down is not in your best interest or hers as well. So we kind of nailed it down in terms of Could be something going on with a stroke. Could be something going on with cardiac. Could be something going on with trauma. Could be something going on in terms of hyper K. And so the list goes on and on. That's for even before we push it a whole lot. Michelle, what do you want to do with it? And you told me a little bit already what your plan is. Yep. So she was saying at 88%. So definitely getting her back into a normal range somewhere with oxygen might give you some more information about how long she's been there, right? All right. Let's see. Will, this looks like yours.
Okay. What do we do with this dispatch information? I'm going to start formulating a scene in my head on the way there.
Beautiful.
And once I get there, do my scene side there, figure out whether I need more resources.
So you're right. What else would you want to do outside of this, formulating this in your brain, based on this right here? If you're in city fire and your dispatcher is getting this type of thing, they're going to dispatch a bunch of units to you, right?
Right.
But if you happen to be in the Thule somewhere to where you get this, you're probably not going to get a whole lot of other resources unless you're asking for it.
Right.
So the other thing I'm always thinking about when I get this is, where's my helicopter? Where's my next unit in? What do I need to do in terms of getting there? What else do I need in terms of helping me out with that as well? But you're right, you're starting to formulate that plan in your brain as to what you're going to do based on that, right?
Right.
Okay, cool.
So, GCS 7, C-spine mobilization.
Without doubt.
Quick trauma assessment.
Good. Yep, spot on, good. What else? What's your, from a prognostic standpoint, what do you want to do in terms of treating her? What's your priority?
Let's get that airway.
It's right here, right? Now, it doesn't mean I'm not going to take a look and see whether or not she's got narcotics on board or something like that, but everything points towards a likelihood that she's got a head injury, just exactly like you're talking about, right? And again, airways. So the idea, so here's something else, and we've kind of started talking about this, but let's talk about it just a wee bit more. So while we talk in the class from the fact that we're going to RSI this patient most likely, the idea is going to take time for somebody to pull up that RSI. So if you're knee deep in terms of doing that, or you've got somebody else that's knee deep in doing that, somebody that steps away to pull up your drugs along the way so that your airway becomes much quicker. Make sense? And so that's the other thing that's part of this differential diagnosis, that if this is what's going on in your brain, then you need to get somebody to put that into motion. That's why general impression is such a big deal as far as figuring out what your first steps are. Make sense? Okay.
So diminished right or diminished sounds on the right side.
Yep. Yep. So tomorrow afternoon we're going to study this right here. She needs to have her chest needled based on this right here. And as we'll talk tomorrow afternoon, the idea that just because you have diminished breath sounds on one side, that you need to go to everybody's chest, okay? If we did that, we'd be kneeling fools, right? But to that, the idea based on the mechanism, okay, the mechanism will sometimes take you towards what you need to do along the way, okay? So a priority in terms of life threat would certainly be this. What can you do about this? Well, we can wrap the pelvis. We need to get her somewhere else along the way. Can we do something in terms of trying to control this bleeding? Tourniquet, if nothing else, right? The idea that what she needs is a surgeon, but the idea that she's got multi-system trauma going on, that we'll talk about tomorrow morning, will kind of take you where you need to be.
If you're out in the boonies,
Yeah.
going something like that,
Yeah.
limited resources, or even in town,
Yeah.
you know, our doctor's going to complain about throwing a quick tourniquet on and calling it quits, not even messing with it.
So-
There's a lot going on.
So again, Travis,